First of all, I'd like to thank everybody that is here and put the effort and time to get here. Dolores, Caitlin, thanks for the help with the internet and the programming, because I would have still been back there. I want to thank Dr. Henderson, even though he isn't here, Dr. Francomano and Dr. Liu. I bounce things off them all of the time, and they're a really good asset to have. I'd be remiss if I didn't thank my wife. She's my rock. There's no question about it, so thank you very, very much. So this case study, I want to let you know, you're going to see some videos here. You're going to see the girl's face. Everything was, she signed off on this. Everything she said, go ahead and use it if it can help somebody here to go ahead and do it. So her name was Emily. She was a 22-year-old female. Her diagnosis when she came in was kind of like all of you, EDS, Chiari, tethered cord, CCI, spinal instability, POTS, mast cell activation disorder, and dystonias. I'm going to kind of move through this because this is kind of important, but the videos really show what was going on with her. Her history, up till 2005, she was what everybody would consider a normal child. She grew up with no problems at all. Her first symptoms were severe headaches, neck pain, back pain, dizziness, and fatigue. In 2006, she was diagnosed with Chiari, a retroflexed odontoid, EDS, tethered cord, and POTS. She had some surgeries and had improvements with all of those symptoms. 2008 to 2009, she was diagnosed with craniocervical instability and cervical instability. She had an occiput to C3 fusion. Post-surgical, again, nearly all the neurologic symptoms resolved, and she was doing very well. The POTS symptom improved dramatically. In 2011, they found a C4-5 discectomy and fusion, and it was triggered by her looking down for several days in a row, is the way she presented it to me. 2012, C3, C4, and C5, C6 discectomy with fusion. Sounds like all of you guys. It seems like it's just the same thing over. 2013, she was diagnosed with mast cell disorder, C6, C7, discectomy and fusion, and she had multiple LP shunts that year. 2014, again, more surgeries, C7 to T3, fusion, and she described it as just prolonged looking down, doing schoolwork, reading, just aggravated that area, and it was, and then she needed the fusions. 2016, she had a T2 to T7 fusion with the Arthrex tape. 2017 was the start of her dystonic activity. She was diagnosed with serotonin syndrome. Then she had a T6 to S1 fusion, needed by months of wild dystonic activities, is the way she described it. And December 6th, 2017, the dystonias were coming on 2 times a day for anywhere from 2 to 5 hours a day. She started with severe anxiety, panic attacks, paranoia, really bad OCD. So the way she would describe some of the dystonias, any type of loud noise, anything that would startle her, if she got cold and began to shiver, it would immediately trigger one of the dystonic events. And she always would know, there was almost like a prodrome like you have with a migraine. She knew it was coming on. She felt weird, is what she would say. And then the cascade of getting her ready to go through this anywhere from 2 to 5 hour dystonia, it started. She would get in bed, whatever her parents wanted to do with her. The dystonias, I'm going to read this kind of quick. Repeated yawning, toe and finger curling with flexion. She would begin to not be able to swallow, severe temperature swings, arms and legs lost control. It was more on the left side. That was where it would begin at and kind of trickle over to the right. She could do a stomach crunch beyond belief. I mean, she would come up as far as her tape would let her, and if I had abs like her, I'd be really happy. The diaphragmatic dystonias were obviously a huge concern because she would stop breathing for 30 to 45 seconds at a time. She would sniff repeatedly. Her spine would jerk back and forth, side to side. If she had to use the bathroom, she had to immediately go. She couldn't wait. She had to get there, whether the dystonia was coming or not. She had to get there. Severe head extension, which again was troublesome with the surgical interventions that she had. Dizziness, facial and mouth twitching. Her eyes would dart and get stuck in a certain position at times with this, and her heart rate would increase from 130 to 180 beats a minute resting during the dystonia. So post-dystonias, which again, like I said, they were anywhere from 2 to 5 hours, her legs would just contract so much that she couldn't walk. She had acidosis in her legs so bad that she needed fluids. A PICC line was administered in 2017 to administer fluids. Prior to when she would get that weird feeling, they would give her Benadryl and Ativan. And again, as it started to cascade downhill, and that's what her parents said, it was just kind of a downward spiral with each one. OCD panic attacks, almost irrational behavior from her. Any type of overstimulation with light, people, anything like that. She couldn't do her schoolwork. It was very, very difficult. The medications she was on before I saw her were clonidine, propranolol, Valium, baclofen, Ativan, Benadryl, Cogentin, Depakote, cyproheptadine, 5-HTP with B6, ashwagandha, CBD oil, and a Myers cocktail infusion. This is what she walked into my office with. And that would go on. It's kind of tough. That would go on for anywhere from 2 to 5 hours straight, twice a day. Twice a day. She would have one in the mid to late morning, have about an hour reprieve, and then have one from 4 to 8 o'clock at night. So, and this is a very brief exam overview. The first day I saw her, I spent about 3 hours with her doing an examination, and her resting heart rate, just kind of sitting there, was anywhere from 100 to 105 beats a minute. Her SpO2 was pretty good, how much oxygen she was taking in. Her pupils, it was funny, her dad was there, and he called them death eyes. Pupils were fully dilated. There was black and there was white. That was it. Some of the neurologic stuff, I could have listed everything, but some of the ones that I thought were really important, we did some eye tests. Her saccades were really, really slow to the left. That was a very quick eye motion going to the left. The anti-saccades, which is, I would wiggle my fingers and have her look the opposite way of the finger that I wiggled, were really, really, really good. And all this stuff is telling me something as I'm looking at her. She had a ton of cerebellar findings, multiple left-sided findings, including finger to nose, Romberg's position, where you would stand with your eyes closed. She would fall to the left. Tandem stance, she falls to the left. There's some testing that I do from a functional neurologic standpoint where I would have her eyes closed, look up to the left, look down to the right, look up to the right, look down to the left, looking at what type of cerebellar planes those eyes are in. And it's just telling me from a functional neurologic standpoint what is going on with her. Cortical testing, meaning looking at how her prefrontal cortex is actually working. There's things that you can do, finger tapping, which is a good neurologic test. Left side was very, very difficult for her to do. There's tests called Loria and drumming. They were all performed fairly accurately. Sequencing of hand motions, she really struggled with, but she did it pretty well. Again, more cortical tests for like the Stroop test, where you see the color, you see the word red, but it's like blue, and you have to say blue. She did that really, really well. And again, contrasting finger sequences where I would put up one finger, she would have to put up two. Again, did that very, very, very well. So looking at that, my thoughts were, and you could figure out whatever four-letter words you want to put in there. I'm like, what the heck is, what is going on here? But with my training in functional neurology, I look at things a little bit different. My thought process is you have to treat the person looking at what is their lowest basic functioning level. And if your autonomics are not working very well, it's really hard to build on anything, because if you can't maintain homeostasis, if you can't have a good resting heart rate, if you don't sleep, if you can't digest food, it's really tough to build on anything physical if you can't do the most basic things. So in the back of my mind, I'm thinking she's got some stuff going on there that she needs to work on. She definitely had a proprioceptive problem. And if you don't know where you are in space, you're not going to function well from a motor output. And the brain problem, she definitely had some anxiety, some panic attacks, and OCD. I thought of this through, and she's seen multiple docs. I knew it wasn't a tumor. I knew it wasn't anything like. It seemed like these dystonias were a functional problem. And ultimately, I think all of us, we are a sensory-driven being. We are what we see, smell, touch, taste, hear, and the biggest input we get and the most constant is from gravity. And she just wasn't doing a real good job resisting gravity. So why I thought it was a sensory problem, there's multiple studies that are out there. I picked a couple of them that kind of look at it as a sensory problem. What can be causing some of this? So the trigeminal nucleus is a sensory component in the brainstem that kind of integrates a lot of input coming from the face. There's a ton of literature out there regarding sensory and motor disorders and how there's a mismatch and kind of how 1 + 1 isn't 2 coming in. There's articles out there with cervical dystonias where it's a neural integrator problem. There's something in your brainstem called the interstitial nucleus of Cajal that kind of gets some input coming in and has to disseminate it and say what's good and what's bad. And again, abnormal cerebellar processing of neck proprioceptive information drives cervical dystonia. So I think I had a decent basis on why I wanted to do what I wanted to do. And so the treatment started February 12th of 2018. And a lot of you, when you're reading this, are saying, there's no way you did this, but I did. You can ask my wife. I saw her for 3 weeks, Monday through Friday, some Saturdays, 5 days a week for 7 to 9 hours a day. And I basically went to war with these problems. I didn't stop. We sat next to her. We did the therapies that I felt were appropriate. And we did cranial nerve stimulation. We did eye exercises, light stimulation, auditory stimulation. Again, saccades and pursuits. We did some hemi-stimulation with her visual fields. We did some cerebellar exercises. We retaught her how to cross-crawl, which she did poorly. We did some balance exercises, and we also did some gait training. So the results, and this was really amazing, once I got her where she could sit up and get through some of the episodes is what we started calling them. The D word was not used anymore. But once the dystonias, once she was able to inhibit the motion of her arms and legs, she was actually able to do that the very first day while she was laying down. And it just slowly decreased the entire time her motions. We finally got her seated, and we actually finally got her up and moving during an actual episode where she felt like that weird feeling was coming on. She slowly decreased and stopped all of the Ativan and Benadryl. She was able to sit and walk through the episodes, as we called them then. Her heart rate would decrease into the mid-90s to mid-80s to low 90s. The PICC line was removed April 12th, and the dystonias completely stopped May 1st, completely gone. And The date is up there, and this is 2 days after we started care. All of the videos you're going to see are during a dystonic event, is what she perceived as a dystonia. So that's a little better than the first video. Her legs are bent like that because that was very comfortable for her. But that's in the middle of a dystonia that would usually last, 3 to 5 hours. She didn't gain that much weight. Did that come out? This was, again, in the middle of a dystonic event 4 days into the treatment. She's actually sitting through her dystonia. And you're going to see, I hope that shows up, but you'll see a little facial twitching. You may see a little motion in her feet. You'll see her left arm kind of go a little bit, and then she was able to inhibit it. There's the facial, a little bit of, you could see the SCMs, the muscles right here kind of contract, and her face kind of scrunches down. But that is as bad as it got. A week into it, five days into it. So there was not much. Once I had her seated and the dystonias were gone, I knew we were on the right path. Once you could resist gravity a little bit and control your motor output, I knew we were going the right way. This was a week into it. This is in the middle of a perceived dystonia that she was having, able to do motor tasks without causing a dystonic event. Like I said, that was in the middle of a dystonia. And we did a lot of different things with her that improved her rather rapidly. None of it was medication-based. It was all basically somatosensory stimulation. So my thought process for this is if there was abnormal somatosensory input, it kind of screwed up the input coming in. It would be like getting 1 + 1 is 6 coming into your system all the time. You're never getting 2 coming out, never. So what we did was we increased the firing to cortical centers as well as brainstem centers for appropriate descending controls of her motor system. All of your motor system is controlled by your brain. And a lot of it comes from the prefrontal cortex, which is where you get a lot of your inhibitory pathways down to motor systems, autonomic systems, and all of that. For the docs in the room, because this is kind of, if you think about the pontocerebello-thalamocortical, striatopalatal thalamocortical loop, and is where you get some of these inhibitory pathways. You have your direct pathway, which is for motor involvement, and your indirect pathway, which kind of shuts things down and lets you move appropriately. Hers was not working well. Basically what we did, we cranked up her brain to start functioning correctly. And going forward, that's her on May 26th. She's hanging out with her brother. I hope they're not off-roading. I hope they're just going for a ride or, around town. And even though this slide did not, I added one, but she showed me a pulse ox with how much oxygen level and her pulse. And her pulse ox said 97% and her heart rate was 73. And underneath it, there was a little text that said, I texted her something, she texted me back, and she said, cool. She goes, I'm actually going to be driving soon, with a big smiley face. So, again, a little different therapy. I personally think going forward, and this might be a little premature with some of the people here, but I think a lot of the dysautonomic problems, I think a lot of the dystonia problems that come with all of these disease processes, the orthostatic intolerance, the POTS, problems. I think going forward, a lot of this is going to be found that it is a sensory problem. It is a sensory integrative problem that you have some systems that are firing saying 1 and 1 is 2, another one saying 1 and 1 is 2, but you got that one that's telling you 6. And you just can't mix and match all of those things together to get a good output. So, that's where I came with this. We got a really good result. We've seen other patients that have had things like this going on with gastric motility problems that are now texting me little emojis with the, you know what emoji I'm talking about, with a little smiley face saying, we're good. I kind of get tired of getting those every day, but that's beside the point. But I do believe going forward, and I think this is going to play out, that a lot of these concomitant problems that come with these connective tissue disorders, Chiari, I think you're going to find out this is a sensory, integrative, sensory-driven problem that if you know how to correct that, people can get really, really good results. So, that's my new office. I went all in. I basically left my office that I had for 25 years, and I'm starting my own, just kind of treating EDS patients and POTS and dysautonomic patients. So if you know anybody that I've treated so far, you will know that I will give 110% to you guys. And I'm sure some of you know some of them, but you're a great group. I would go to war with you guys anytime because you guys don't quit. You really don't. Thank you all very, very much.